In this video, Unit 6, Central Nervous System, we are going to talk about some psychotropic agents, specifically those to treat depression, mania, and bipolar disorder or manic depressive episodes. So the psychotropic agents are agents which are, it's sort of a general term which denotes drugs that are going to alter the functioning of the mind. So psychotropics are used to treat oftentimes depression, in this case, anxiety, manic depression, and bipolar disorder. So these are what we refer to as the affective disorders. And an affective disorder is a disorder that is characterized by extremes of the mood. So in the case of depression, depression is categorized by feelings of sadness and or hopelessness that are accompanied with a loss of pleasure in activities that were previously pleasurable. Also, this depression often looks like changes in appetite, maybe loss of appetite or increased appetite, sleep issues, maybe not able to sleep or sleeping too much, energy changes, and possibly, but it's not a prerequisite, to see suicidal ideation. Mania, however, is the opposite of depression in that we see oftentimes overt enthusiasm, oftentimes kind of with like loss of ability to kind of foresee consequences, anger, potentially, rapid thought and speech patterns, impaired judgment, and extreme self-confidence. So these affective disorders are going to be approached in terms of pharmacology by using some of these psychotropic agents. So the first thing I want to talk about is antidepressants. So there's a lot of different antidepressants, and this is covered in a very minimal way in your book, and I'm going to expand it a little bit. Just sort of as a general conversation first, how antidepressants work and why we use these drugs is what we know about most of the antidepressants is that they work by potentiating the action of either norepinephrine, kind of classically norepinephrine, or norepinephrine and serotonin, or just serotonin. So they potentiate the action of those agents, those neurochemicals at the synapse. So historically, depression has been thought of as a deficiency in kind of classically norepinephrine. But again, that's been expanded to the other monoamine, serotonin or 5-HT. So the monoamine theory of mood proposes that depression is due to a deficiency in these monoamines. Like I said, historically it was norepinephrine, but now we're thinking more norepinephrine and serotonin. And the mania would be the flip side of that, too much of those chemicals at the synapse. But what we know is it's way harder to understand than that. That's an oversimplified, grossly oversimplified definition of these problems. However, I will say that the antidepressants that work by targeting norepinephrine and or serotonin, these work for a lot of people. So this is definitely part of the picture, but they're not curative. And oftentimes their efficacy doesn't last over the long haul. So that's why we say oversimplified. So kind of historically, the mechanism of action of these psychotropic agents is the antidepressants kind of classically will increase serotonin or norepinephrine at the synapse, and we'll talk about how and why that happens in a minute. And anti-anxiety agents will, from some perspective, decrease norepinephrine at the synapse. And like I said, lots of people have some improvement with these approaches. So the categories of the drugs we're going to talk about for depression are the selective serotonin reuptake inhibitors, or the SSRIs, which are going to specifically inhibit serotonin reuptake, and they're going to minimally block a few other receptors, the muscarinic alpha adrenergic, histamine receptors, H1 receptors. Then the SNRIs, which are the serotonin and norepinephrine reuptake inhibitors, the atypical antidepressants, which are still going to target norepinephrine and serotonin, but sometimes like sub-receptor types. tricyclic antidepressants, which were the first antidepressants and are still considered very helpful for major depression, but they have a lot of side effects, and for that reason, the other ones will be usually tried first. And then the monoamine oxidase inhibitors, which are going to inhibit the enzyme monoamine oxidase, and they're going to decrease the availability of serotonin and norepinephrine, primarily norepinephrine. They're going to work well, but they have a lot of drug-food interaction, so that's why those are not, they're historically considered last-line agents. So let's start by looking at the selective serotonin reuptake inhibitors. I gave you some examples up there. The prototype is FLUOXETINE, which is Prozac. CITALOPRAM is another one that's used frequently, which is Celexa. Paroxetine is Paxil. What else do I have up there? Zoloft is Sertraline. And if I skipped one, ESCITALOPRAM is Lexapro, the second one in. All right, so these guys, the mechanism of action of these drugs is they're going to block the reuptake of serotonin. They're going to increase the concentration of serotonin. So they're selective serotonin reuptake inhibitors. So we're really thinking of serotonin here. And therefore, we're going to increase the serotonin availability at the synapse. These drugs usually take a couple weeks to see any improvement at all, and sometimes up to 3 months before you reach kind of the maximum benefit, which tells us that this is more complicated, because as soon as someone gets one of these drugs on board, there's definitely more serotonin in the synapse, but that serotonin isn't really doing anything, so that tells us there's more to this picture, obviously. One of the thoughts here, and this is excuse me, pretty common across the board with antidepressants, there's this sort of window where it takes a period of time before they're effective, and then a little more time before they're completely effective, and then oftentimes they lose efficacy at some point in the treatment, and that's variable from patient to patient. So that tells us there's something more than just serotonin going on, and what it seems that in the case of serotonin and also in the case of norepi, when there's higher levels of those neurotransmitters in the synapse, the higher level of neurotransmitter causes a stimulation of a presynaptic alpha receptor, which seems to decrease the further release of those monoamines into the synapse. So it sort of turns down the volume, if you will. In my mind, it seems kind of like a protective mechanism, like, oh, there's way more neurotransmitter than normally would be there, and so it's a way for the body to kind of regulate that, sort of like a feedback mechanism. That seems like after a little bit of time, that feedback mechanism kind of dampens, and so then you start to see the efficacy starting. So therapeutically, these drugs are used for depression. Obviously, they're antidepressants, but you can see they're also tried for other situations like OCD, obsessive compulsive disorder, panic disorder, generalized anxiety disorder, post-traumatic stress, social anxiety disorder, premenstrual dysphoric disorder, bulimia, but for bulimia, it's specifically Prozac. These drugs are considered first line because they have fewer side effects than the other ones, specifically the TCAs, the tricyclics, and the monoamine oxidase inhibitors. The common side effects with serotonin reuptake inhibition is going to be headaches, sweating, anxiety and agitation, GI effects, mostly nausea, maybe some vomiting, weakness and fatigue. Sexual dysfunction is very common and one of the biggest issues with these. Weight gain is also quite common. And sleep disturbances, either they're not able to sleep or they're sleeping too much, are all pretty common side effects of these drugs. The next are the serotonin norepinephrine reuptake inhibitors. So we're throwing in another neurotransmitter. It's the same kind of idea. These are reuptake inhibitors, so they're going to keep, in this case, serotonin and norepinephrine there longer. Venlafaxine is Effexor. DULOXETINE is Cymbalta. DESVENLAFAXINE is a drug called Pristiq. There's a few others, but those are the ones that might be familiar. You might be familiar with these. So generally, we'll try the SSRIs first, and if those fails, we'll grab these. Try one of these. I think pretty much SSRIs are considered first line by most people. One of the caveats about these drugs is if the patient has depression that's accompanying a chronic pain picture, which is quite common, people who have chronic pain oftentimes are depressed, then these drugs might be selected first for that reason. The tricyclics are also helpful for pain. The tricyclics are going to act similarly in that they're going to play around with the serotonin and the norepinephrine availabilities, but the serotonin norepinephrine reuptake inhibitors have fewer side effects than the tricyclics, and the side effects are going to be mostly the same in this case as the selective serotonin reuptake inhibitors. I just want to mention atypicals for a second. We're not going to get into a lot of them, but so these they're mixed drugs. They act kind of a little bit differently. Still, most of the time playing around with norepinephrine and serotonin. The one that I want to spend a little moment on is the two is Remeron and Wellbutrin. So Wellbutrin or bupropion. So you see we have another neurotransmitter there. So we are seeing some weak dopamine in reuptake inhibition. And also norepinephrine reuptake inhibition. Not as profound of an effect on serotonin, right? They're leaving serotonin out of this. And when you take the serotonin out of the picture, we see a decrease in the incidence of sexual dysfunction. So that sexual dysfunction, which is common with all other antidepressants, and most common with the selective serotonin reuptake inhibition specifically, tells us that the serotonin has something to do with that sexual dysfunction. Remeron or mirtazapine is a drug that enhances serotonin and norepi reuptake by blocking those presynaptic alpha receptors I was just talking about. So they don't play around with the reuptake, but instead they block those presynaptic alpha receptors, which, like I said, seems to turn down the production of those chemicals. So that's an interesting one. But we don't see as much of the sexual issue side effects with these, but we do see a little bit more weight gain and a little more sedation. And then there's some other atypicals that you can look at if you want to. Okay, so the tricyclic antidepressants. These were the first antidepressants on the market. The very first one is the one in the middle, amitriptyline, for which there's no other name at this point. Imipramine is a drug called tofranol. Clopramine is a drug called anafranil. There's others of the tricyclics. So these ones are going to be really potent at inhibiting norepi and serotonin reuptake. So we're going to see the same sorts of side effects that we've been talking about. But these drugs also, in addition to the reuptake mechanism, they seem to block some serotonin receptors, also the alpha-1 receptor, the alpha adrenergic receptors, as well as histamine receptors and muscarinic receptors. So they're going to be really good at elevating the mood and increasing the alertness, but alertness and physical activity in people with major depression. So we really think about these for major depression, severe depression, and you can see that below on treating moderate to severe depression. Sometimes we're going to use these guys also for people with panic disorder. You can see if children that are wetting the bed, although there's other things I would try first, children that are greater than 6 years old. Imipramine specifically has been tried to prevent migraines and also to deal with the chronic pain, so the chronic pain and depression potentially. And then we see low doses oftentimes being used to try to treat insomnia. There's a lot of side effects with these, and this is why we really don't want to use them unless we have to. And the uncomfortable, sort of, troublesome ones are the anti-muscarinic effects. So blurring of the vision, drying of the eyes, drying of the mouth, retention of the urinary retention, as well as constipation, blocking of the parasympathetic slowing of the heart. So instead we'll see what we refer to as a sinus tachycardia, an increase in heart rate. And if someone overdoses on a tricyclic, that can cause a fatal arrhythmia. And then, of course, sedation, weight gain are all very common, as well as all the other adverse effects we've talked about. Sexual dysfunction also happens with the tricyclics, although it doesn't seem to be as pronounced as with just the selective serotonin reuptake inhibitors. So again, we're going to think of tricyclics as really intervention for major depression, severe depression. And some people still consider tricyclics the drug of choice for severe depression, and I believe that's what it says in your book. However, in reality, if you can use something that doesn't have this potential cardiac issue, that would probably be preferable. Monoamine oxidase inhibitors. So these guys are going to inhibit the enzyme monoamine oxidase, which is responsible for deactivating norepinephrine, dopamine, and serotonin, leaving those neurochemicals in the synaptic cleft. So these are effective, right? But they have a lot of interactions with other drugs and food. So because of the drug-food interactions, we've considered these last line agents. However, they can be used to treat depressed people, especially those people who cannot take the other drugs. So if someone's unresponsive to all the other ones we've talked about, or they're allergic to one of those, this might be the way that we have to go. However, they need to be really watched. More drugs interact with MAO inhibitors than don't. So the general rule of thumb is just assume that there is going to be a negative interaction until you prove otherwise. And with the food situation is a big one. So any food that contains tyramine, which is an amino acid, and tyramine's in a lot of stuff, especially a lot of stuff that people like to eat, like aged cheese, deli meats, chicken, liver, pickled and or smoked fish, red wines. I think there's a significant amount of tyramine in chocolate. So these are things that, and I want to say beer too. I think fermented foods in general, if I remember correctly. So what happens if someone is on an MAO inhibitor and they contain a tyramine containing food is that basically the tyramine causes, because of the enzyme inhibition, tyramine causes the release of a huge amount of stored catecholamines, and you sort of get this catecholamine storm, which can cause a hypertensive crisis. So it's a very serious interaction. And so for that reason, unless somebody is proven track record on an MAO inhibitor and it was effective for them and they understand the cautions and they understand what they have to stay away from and you can kind of trust them to do that, then you might consider using these drugs. But other than that, if that's not the case, I would very definitely consider these last line agents. All right, so those are our antidepressants. The last thing I want to talk to you about for a moment is treatment of mania, manic depressive episodes, or bipolar disorder. Those are all sort of similar picture. So remember, mania is the opposite of depression, where we get this like disorganized speech in some cases, sort of this like inability to understand consequence of action, impaired judgment, extreme self-confidence, etc. And that's just mania. And by manic depressive episodes or bipolar disorder is when someone flip-flops between episodes of mania and episodes of depression. So the ideal would be able to stabilize them in between those two extremes. And that's where lithium comes in as a mood stabilizing agent. I'm going to talk more about that one in a minute. Sometimes anti-epileptic agents are tried if mood stabilization on lithium is not achievable. And I give you, we've talked about epilepsy in a different video, but I give you the anti-epileptic agents that are oftentimes used in the case of mania or bipolar disorder. And then if somebody is manic specifically and you're having to decrease that mania, antipsychotics are oftentimes used, which we've talked about in another location as well. But I gave you an example of the three of the antipsychotics that are potentially used. The only drug that I really want to talk about at any length is lithium. So, and this is a very strange drug. Lithium salts are used in an acute setting when someone's acutely manic or bipolar, or prophylactically and ideally to kind of like stabilize them out, which is again why it's called a mood stabilizing agent. And lithium is very effective. We don't really know why it works in this capacity, but it does seem to work for a lot of people. You can see there between 60 to 80% of patients with mania or hypomania are effectively treated with lithium. Again, we don't really know. We know that lithium competes for a bunch of ions, and it's a bit mysterious. But the one thing we do know about lithium is that the therapeutic index is extremely low, which means the dose that helps and the dose that harms they're not far from one another. And so it has to be monitored if someone is being treated with lithium. Their blood lithium levels need to be monitored to make sure that they stay in that therapeutic window and they're not going potentially up into toxic levels. When they're in the therapeutic zone, if you will, there's quite a few side effects. The common ones are headache, dry mouth, polydipsia, which is a lot of drinking, polyuria, which is a lot of urinating, polyphagia is a lot of eating, being very hungry, GI distress, specifically nausea and vomiting. A fine hand tremor is a common symptom, or pardon me, a common side effect of lithium. Dizziness, fatigue, skin rashes, skin reactions, and sedation. When somebody's lithium levels are potentially reaching a toxic level, additional symptoms would be ataxia, which is kind of the inability to speak, so the loss of the ability to speak. That should not say slotted, that should say slurred speech. So this is going to be pretty obvious when they're already taking lithium and there's speech disruption. Either their speech is slurred or they're not able to speak at all. That's something to think about. Coarse tremors are real obvious tremors, confusion and convulsions. Lithium is a known thyroid suppressor, so thyroid function is going to need to be monitored throughout the duration of treatment with lithium. Lithium is excreted by the kidneys, and so we need to watch the kidneys. Kidney function is something that's kind of hard to, or I should say kidney dysfunction, early signs of kidney dysfunction is relatively hard to pick up on standard laboratory analysis. So we're watching their kidney function tests carefully. And if you start to see any change in kidney function, we're going to need to take the lithium out. And that's probably what that or the endocrine suppression are probably the things that limit people from being able to be on lithium. Lithium very definitely is not safe in pregnancy, causes all sorts of problems to the fetus, which you can see cardiovascular malformations, kidney damage, suppression of the thyroid leading to goiter, euthyroid goiter, and also hypoglycemia in the newborn and in that person later in life. So lithium, it can be a very effective drug. It is a very effective drug, but there are some limits, right? Because its safety is, its therapeutic window is so narrow. So if the lithium doesn't work, then we're stuck with having to try to manage these extremes in mood from different angles. So that's where the antipsychotics potentially come in, or the anti-epileptic agents, which are sedating. Antipsychotics are very sedating. Oftentimes what's going to happen is we're going to have someone in manic, so we have to give them a drug to bring them back down, and then they're going to become depressed, and then we have to give them an antidepressant, and then they become manic, and then we give them an antipsychotic. You can kind of get the gist that it's quite tricky. Whereas if you can get something like lithium, a mood stabilizer, just kind of like flatten them out in between the extremes, that would be more desirable. So that concludes our discussion on the psychotropics, specifically around depression and mania, or manic depressive or bipolar disorder. I will speak with you guys later about something else.